when someone has symptom among our study participants, 72 to 75% of our study participants first went to a private clinic, to a private provider. When I say private provider, it means it could be private clinic, informal care, pharmacy, anything. They went there. Their first preference was that. There was a delay of 9 weeks from symptom onset to treatment initiation. They made average 12 visits, that's the average. But then it can go, many patients had actually more than 20 visits before they were diagnosed with TB. So they were roaming around and spending money. Given all this, when I calculate our total cost using the time cost approach, which I say, time loss as the indirect cost, we found that the total treatment cost ranged from 30,000 to 32,000. Okay, that's the time cost approach. But the point is that 58 to 59% of that cost was actually direct cost. That is the money spent. That is the most important point. It's not the time spent, it's the money spent. Next, when we look at the output approach, that is the income loss, then it ranged from 30,000 to 61,000. And you can imagine that this clearly said that there is huge unemployment and income loss because of TB, because that's the way we calculated this income loss, that total cost of TB treatment, right? So, and another very important finding is that 58 to 59% of this cost is incurred during the pre-treatment phase. 30 to 61% of our study participants faced catastrophic cost. So we are far, far away from reaching zero catastrophic cost target. And again, half of them faced the catastrophic cost even before starting the treatment.
Hello, welcome friends to another episode of NTB Dialogues, 90 for 90 Global Voices series. Today, we have amongst us Dr. Susmita Chatterjee. As many of you may be knowing, she is a program lead for health economics, health systems science at the prestigious the George Institute for Global Health, India. She is also a conjoint senior lecturer at University of New South Wales, DBT Wellcome Trust, India Alliance, clinical and public health intermediate fellow, and professor of Prasanna School of Public Health at the Manipal University, and has been a former faculty at the Public Health Foundation of India. So welcome, Dr. Susmita Chatterjee. Thanks a lot for taking out time today for us.
Thank you. Thank you so much for inviting me actually to talk in this forum. Thank you so much.
Thank you so much, Dr. Susmita. It really means a lot because the kind of work which you have been doing is really important because it informs the program and probably to improve the response and so that we can really reach those who are unreached and also make it easier for people to tide through the TB treatment. So before we begin in the conversation, I think I must say that the study was so important because the catastrophic cost, I think it was about 10 years ago in May 2014, all the governments in Geneva at the World Health Assembly promised to eliminate catastrophic costs. Zero catastrophic costs was the promise. Despite TB treatment and diagnostics and a lot of other support, which is provided free of cost by Government of India and also many other governments of TB high burden countries worldwide. There is a lot of substantial catastrophic cost. And so this study and of course, diagnostic delays. It is so important to find people early and accurately with tuberculosis, put them on treatment so that they become untransmittable and stop the spread of infection. It is so critical to reduce human suffering and also to break the chain of transmission. So thanks a lot for doing this study. This was so important. We will provide the link to the study, this publication in the description below. And I don't need to talk about this study myself because we have Dr. Susmita amongst us here. So Dr. Susmita, please tell us more about this. Over to you.
Okay, thank you. Thank you so much again. So yes, as you rightly said, that the government of India actually provides free diagnosis and treatment to TB patients. So now the question is, what was the need of this study? So as you rightly mentioned, that the NTB strategy actually envisioned that there was a milestone of achieving zero catastrophic cost by 2020. And as a signatory of this NTB strategy, we also agreed that we should have like the milestone of achieving zero catastrophic cost by 2020 and the target of achieving zero catastrophic cost for TB affected households by 2025. So that's the target. Now, given that background, we really wanted to know if we want to achieve this target, we really need to know currently what proportion of TB patients in India are facing catastrophic cost, right? So that's the most important information to reach the zero target. Now, there are, of course, few small scale studies, but we wanted to do in a much larger scale so that we can really say that this is what is the situation. And we also wanted to look at other economic components of the study, like other economic consequences of TB patients. Okay, it's not only the catastrophic cost, but there could be other things. And what are the drivers of catastrophic cost actually? So, given that, we started this study in 4 states, and those states were actually selected based on several criteria. It was not our choice; it was based on several criteria. 1,482 TB patients from these 4 states, Assam, West Bengal, Maharashtra, and Tamil Nadu, were interviewed. They were drug susceptible, but we had also 149 drug-resistant TB patients who were interviewed throughout their treatment period and beyond. We went back about 7 to 8 months of their post-treatment, and then we actually asked them all about their economic condition during symptom onset to treatment initiation, during treatment period, and beyond. So there were actually 3 phases. What we call is pre-treatment, which is like the before starting the treatment, what happened, during the treatment, what happened, and then after that, what happened. So that's the whole story about the economic hardship of these patients. So, as I said, our patients were from 4 states. They were from 16 districts, 118 TB units. So, just for your information, that one TB unit covers approximately 200,000 population. So, you can imagine 118 TB units, it's very spread out, like patients are from anywhere. And then also 182 tea gardens. Now, I want to tell you one point. Our study participants, these 1,482, they were from different groups and they were representative of that group. So at the end of the day, if I say that this is the cost of treatment for TB patients in general population, wherever you go in India, you will get that average cost. So our patients, our sample size was estimated in such a way so that they represent those groups. Now, why did we take these 3 different types of people? Why did we need these groups? Because patients in general population is fine, but in National Strategic Plan for TB, there are few high risk groups. For example, people living in urban slum areas, people living in tea garden areas, because of their very poor living condition. It could be overcrowded. It could be like in tea garden, this is not overcrowded, but this is like, there is no ventilation in their rooms. There could be 3, 4 rooms, but there is no ventilation. So because of this kind of an urban slums are so congested, it's such a bad hygiene, drinking water facilities and everything. So these people are at very high risk of having TB. So that's why we took these 2 high-risk groups and 1 from general population just to see whether there is any difference in terms of their treatment-seeking behavior, cost, catastrophic cost, outcome. If there is any difference, and government needs to do something differently for these groups. So that was the objective of taking people from different population. Now, if I tell you very briefly about our cost methodology, we followed the WHO methodology. WHO has a guideline for estimating the cost and catastrophic cost for TB patients. We exactly followed that. Only thing was that we followed a cohort, but they generally say cross-sectional, but we thought we'll do a cohort study. We estimated, so the total TB treatment cost was defined as direct and indirect cost. So direct cost, when I say direct cost, it means that's actual money spent. So anything from my symptom onset till the initiation of treatment and during treatment, whatever the money spent is the direct cost. And then indirect cost is there could be two ways of estimating. One is like time cost. Because of TB treatment, there will be time loss for the TB patient and their guardians. So we value that. So that way, one is one way of doing it, which is human capital approach. And then another approach is household income loss. So, like if a TB patient is the main earner of the family, and if he lost his employment because of TB, there is a huge income loss, right? So we estimate that income loss. How we estimate pre-TB household income and during TB household income? We estimate this way, and this is called output approach. So in this two approach, TB, so WHO guidelines says that we should do both, but focus on output approach. We did both. And so that is how total treatment cost was calculated. And then catastrophic cost was calculated. The formula is that total cost, total TB treatment cost, if it is more than and equal to 20% of pre-TB annual household income, then it is catastrophic. So that was the methods of doing it. What we found is that the characteristics were very similar what we find in worldwide like TB patient. Those are mostly male and young and productive age group. So those were affected by TB. So that is very similar. But what we then found was that when someone has symptom among our study participants, 72 to 75% of our study participants first went to a private clinic, to a private provider. When I say private provider, it means it could be private clinic, informal care, pharmacy, anything. They went there. Their first preference was that. There was a delay of 9 weeks from symptom onset to treatment initiation. Acceptable delay is generally 4 weeks, but we are at 9 weeks at this point. Because of this delay, they spent money. You know what they did during this period? They did not ignore their symptom much. At least our participants, they ignored for 2 weeks. But then next 7 weeks, they actually roamed around. They made average 12 visits. That's the average. But then it can go, many patients had actually more than 20 visits before they were diagnosed with TB. So they were roaming around and spending money. Given all this, when I calculate our total cost using the time cost approach, which I say, time loss as the indirect cost, we found that the total treatment cost ranged from 30,000 to 32,000. Okay, that's the time cost approach. But the point is that 58 to 59% of that cost was actually direct cost. That is the money spent. That is the most important point. It's not the time spent, it's the money spent. Next, when we look at the output approach, that is the income loss, then it ranged from 30,000 to 61,000. And you can imagine that this clearly said that there is huge unemployment and income loss because of TB, because that's the way we calculated this income loss, that total cost of TB treatment, right? So, and another very important finding is that 58 to 59% of this cost is incurred during the pre-treatment phase. 30 to 61% of our study participants faced catastrophic cost. So we are far, far away from reaching zero catastrophic cost target. And again, half of them faced the catastrophic cost even before starting the treatment.
Yeah. Thanks a lot for sharing these highlights and also taking us through the study. And it's so important. It is so shocking also. 9 weeks diagnostic delay. Imagine, and the number of visits, average visits which you found, like 12 visits at least. Like, this is really amazing. So you also mentioned that there were drug-resistant TB cases also, 149, I guess, or something. So
149.
Right. And so were there any differences between catastrophic cause, diagnostic delays between, did you look at that? Please, can you put yeah.
Of course, we looked at that. So the diagnostic delay, if I say, it is 14 weeks for the drug-resistant TB. Because we can imagine that, because they require a lot more tests to figure out that they have drug-resistant TB, right? So that's why the delay is now 14 weeks. And when I looked at the catastrophic cost faced by them, 32%, like out of 149, 32% faced catastrophic cost before starting the treatment. So that was the situation. So it's really shocking, and yeah.
So true. And also this, one of the things which really resonated with with what we have been talking to people with TB, people who have successfully or completed the treatment or are going through the treatment in India and many other countries. One of the things which resonated, findings which resonated with us was, that the most of the cost was incurred before the correct and accurate diagnostics. Dr. Susmita, I still remember a very powerful interview of a person. She is still undergoing treatment for bone TB and lung TB and spinal TB, like all three combined, in Bangalore right now. So she said that she suffered, and it's already 2 years for therapy. And she said that she suffered more before accurate diagnosis was made,
Yes.
than what she has suffered in the last 2 years. And she probably, let's hope and let's pray that she completes the cure and recovers fully. All our prayers and best of wishes for her. But her statement is, I just can't forget that, like not only her, but like so many people have said that they suffered so much more before, till the point they really got diagnosed and put on treatment. So like it's like a lot of suffering, human suffering happens um, uh, in the journey to get accurate and diagnosed. So your reflections, like how it is so important from public health point of view, from even from a person point of view. So if I'm suffering from TB, it is important for me to get on the right diagnosis and right treatment so that to reduce human suffering. So just your reflections.
Sure, we have also seen that. Like many of our 1,482 TB patients, many, and the drug resistant particularly, they had so much suffering before they were diagnosed with TB. So my what we understood during this period, one point is clear, that the community needs to be empowered. Empowered where, like, we asked few knowledge questions, TB related knowledge questions at the end of, after the treatment completion interview. That is, we went back after 7-8 months of treatment completion, and then we asked few knowledge related questions of TB. And it was a shock to see that even after successfully completing TB treatment, over half of the patients did not know how can one get TB, how can one prevent TB. Where, and then that actually was shocking for us, because if you ask me about any disease, I may not know, but when I went through the disease, I'm cured with the disease, still I don't know how did I get this, what is this disease, what are the symptoms. So that actually, we started thinking about this community empowerment, about the knowledge, that is also acknowledged by WHO, and then a national prevalence survey. They also showed that the TB knowledge is very poor among the community. So that is, I felt that we have done several other things, right? We did active case finding, we did private sector engagement, but we never really looked at the other side of the story, that is the community. We never empowered. We never said, like, I was thinking of like World Health Day, my health, my right. So I envision that we should empower them in such a way that they know that this is condition, that they know the symptoms, they identify their symptoms, and then they go to the right place. Actually, what happened is, I also felt, this was not done in our study, but we also felt that there was not much faith on the government health facilities. And so they first went to the private, as we can clearly see that 72 to 75% of our patients first went to our private. Now, many of our patients said that they did not know that there is, even in a government hospital, there is a separate TB unit where they can go and get tested quickly. If they directly go there I'm only assuming, say, for example, just lung TB, okay, because that's sputum and X-ray. So if they go directly there, get tested quickly, right? So that information is missing. I have seen cases, we have seen cases where the TB patient, the TB unit is just opposite the road of the house of the patient. The patient went to a different state to get treatment. And when I said why, he said I didn't know. So that's very shocking. These are very shocking stories, you know. So yeah, I think that is one point which we should focus on.
So important. All the points which you have just made, and of course, like community engagement is so important. Actually, keeping people in the center while designing these programs, I think that is also very important. That shift is happening, but it is probably
Yes,
needs to happen much faster
much
and
faster.
quicker. Yeah.
Yes.
Totally. And you know what, when you said about I'm right now in Delhi, and so when I speak to people undergoing therapy in Delhi hospitals like Lok Nayak and others, I'm also amazed. They come from Madhya Pradesh and cities from UP, Bihar, and I'm like, it's the same treatment, the same therapy, and you have the
Yes.
state of the art things there too. So it's really important, I think, about the awareness. Yesterday, I went to a site where a group is helping support the people who are homeless. And the most striking part is that the retention rate is very high through the treatment because of the support of the volunteers who and the distance between the one of the very prestigious chest clinic and the person's house was hardly 200-300 meters. So imagine the person is undiagnosed,
Yes.
unreached, just behind in
Behind. Yeah.
the chest clinic almost. So you're very right, like in terms of health literacy, and we have seen there are other examples from HIV, for example, how health literacy and treatment literacy has made
Yes.
a huge difference in terms of taking ownership, as you rightly said, my health, my right, of World
Yes.
Health Day message. I think that has really been very phenomenal to shape people's responses and health-seeking behavior as well.
Of
So,
course.
Dr. Susmita, I know you must be under hard pressed for time. So, um, we would like to have your insights on how can we do better? How can we do better in finding all TB, in key populations? A lot of TB probably is is in these key populations as per the data in different studies. And probably the initiatives are, we need to find early and accurately find all TB to stop the spread of infection. And this is so we are talking about two things here. One is like, um, um, oh, one, we of course have to stop missing cases in the community. But also when we are screening them, we need to screen them with tools which are really more sensitive and highly accurate. So clearly talking about WHO recommended call for replacing microscopy with molecular tests, and this is so important to ensure that people who take a TB test, they are not missed. They are really they have the best of chance to get diagnosed accurately and put on treatment as early as possible. I think this is such an important one. The second insight is you work with key populations, or it's such an important study. Or how can we reach them early, because it is so important to reach the unreached? Over to you.
Reaching the unreached. There are two things. There is one as there is a proportion who are asymptomatic, which is who are really difficult to reach, and there are a lot of there needs to be some advanced technology and stuff to reach them. But my concern is something else, the proportion who are symptomatic. But why there is delay there? My point is in that because we worked with those who already had symptoms, but then there was a delay. I, from my study perspective, if you ask me, I would suggest, I think that we also need to make sure that they are diagnosed quickly. Those, because during this 9 weeks period, they are actually infecting others, right? So I'm not thinking of the asymptomatic. That's a more complex situation. But let's think of the symptomatic patients. But why there is so much of delay? And our study showed the delay is not only from the private sector, it's also from the public sector. We also looked at the missed opportunities, like how many times they went to the government, how many times they went to the private, and then missed. The provider actually missed diagnose them. So I here, given this population who are already symptomatic and going to get diagnosed, and still there is so much of delay, I think that the more training of the provider, more engagement, private sector engagement is there, but it's more like more intense private sector engagement, more training to the provider to identify quickly. And yeah, so that's one thing which I'm sure that we need to really do. And another thing I think is the contact tracing, like those who already had TB. So in fact, in the tea garden area, which I found is kind of missing, there was not much, I have seen that contact tracing is going on, but I think we should focus more on those, so that at least who are symptomatic, we can get them. And if we focus on contact tracing, that means that we are getting a population, right, who are at risk of having TB. So these are my thoughts given the study and what we have seen in the field.
Yeah. Thank you so much, because this is so important. You're very right. First of all, we cannot afford, this is so unacceptable. We cannot afford to miss those who have symptoms. They need to, of course, be put on treatment and care. They need the early diagnosis, and we need to look at those reasons which your study shines a spotlight on how, on how we can do better in ensuring that those who have symptoms, they are at least diagnosed accurately and put on treatment and care. And of course, the barriers like catastrophic costs, etc., are need to be eliminated as quickly as possible. And definitely, we need to do more about the asymptomatic. You're very right. We
Yes.
have there are a lot of pilots happening with ultra portable X-ray machines, WHO recommended, and they are really showing a lot of results. And but they need to go to scale. Like this is also very important. And contact tracing point is also so more important. These are such a missed opportunities. Let's hope the change happens. Any final remarks? And of course, your message for the upcoming World Health Day.
So one point which I think we did not talk about here more in detail is the unemployment and income loss, which we really found is an issue. Now, we have seen that the baseline unemployment rate before TB unemployment rate, and during TB it went up huge. Like unemployment rate was huge. Like it went up, you can say, from 10% to 67% of unemployment during treatment period. So 55% actually were unemployed during TB treatment. Okay. So now what to do with them? Like if they lost their income in such a way for months, say for 6 months, that means a huge loss. And to cope up with this situation, they borrowed, they sold their assets, they have done several things, took out their children from tuitions, from schools. They did so many other things to manage the situation. Now, one thing I would definitely we recommend that there should be a restructuring or protection of these patients from their unemployment, like protection of their livelihood is so much required for this, because many of these patients are unfortunately in the informal sector, right? Most of our labor force is most of in the informal sector. Around patients are also like daily wage earners or something like that. So how can we protect them? So it's again right, and my health and my right, because I'm I I'm I am suffering from a disease, but now what about my livelihood? Who is going to support this livelihood? Because I'm not getting anything. So I was we were disseminating our results. The tea garden doctors, managers, they were saying that there could be an opportunity, like pregnant women get 6 months of paid sick leave in the tea gardens. So, like, why don't a TB patient get that sick leave? Paid sick leave, so these are, and then our patient said that those who are, say, vegetable vendor or the tea garden workers who pluck tea leaves, they cannot pluck their leaves and they plug their leaves, but they cannot carry this 20, 25 kg on their back every day when they have TB. So restructuring of the employment status, not giving them that work, but there are a lot more work in the tea gardens. Why don't they give some other work, alternate job opportunity to these people so that their income is not lost, their livelihood is maintained? So this is another point which we really, really want to highlight and want to also ensure that if the pre-treatment phases cost can be covered by some way. I'm sure that because outpatient costs are not covered by any insurance program, right? But I'm assuming that that is huge for many, many diseases, including TB. So why not we think about this? So these are my final thoughts about our work, and we really want to make some changes here.
Yeah, sure, sure. Thank you so much. This is this is so important, and particularly the final remarks which we have just made. So important, and this also resonates probably with other diseases as well. A lot of the recommendations which you have made are so true. We need to look at um, um, uh, uh, health system as a whole and make sure that these obstacles and barriers which block access to existing care services and make it so difficult for people, even despite the treatment being free, for
Yes.
other conditions as well. But of course, right now we're looking at tuberculosis. But I think a lot of insights and from your study and which can probably influence health responses as well. So thanks a lot, Dr. Susmita. Really insightful listening to you this morning, and a real pleasure also talking to you.
Thank
So
you so much.
thanks a lot, and we really look forward to your study making a impact not only in India but also in other high burden countries. It is absolutely unacceptable in 2024 to have catastrophic costs, which was recognized 10 years ago by our governments to eliminate it, still being a barrier. The more action is definitely needed here. And of course, the other all other findings of the study, including diagnostic delays. No excuse for any kind of diagnostic delays if we are to end TB. The stopping the spread of infection is so important, equally important as reducing human suffering because of TB. No one needs to suffer from TB, and of course, or get TB, because TB prevention is so possible. Thank you, Dr. Susmita. Thank you again.